again, I'm very excited to be here. I'm very humbled to be in such an illustrious panel. I've been using the course test, the CardioDx test, for probably about 3 years now. So I'm pretty excited to share some of my experiences with it. So the challenge in clinical cardiology, which is primarily what I do, I'm an invasive cardiologist with Novant in North Carolina. But I can actually speak for the 41 of us in our group that the challenge that we face is how do you identify chest pain when they're coming in, especially when they're not coming in with those typical Diamond Forrester presentations. And you're seeing chest pain present more and more frequently. However, if you look at the trends, less than 10% of the time is it actually obstructive coronary artery disease or stable angina. Usually it's something totally non-cardiac, musculoskeletal, GI, et cetera, et cetera. Well, we've heard about the overutilization of cardiac imaging, and to the tune of nearly $4 billion a year, and an exorbitant amount of radiation. Many of these people still have to go through to our cath lab. I talked about genomics. It's a new era. Ever since the Human Genome Project at the turn of the century, now we can localize disease. We can match them with the disease process. We can match them on the exact loci where the disease is happening. This is a whole new level where we take the promise of the future of medicine and now translate it into becoming the practice of medicine. So I'm pretty excited about where we are now with the coronary disease. And what I wanted to point out on this slide was there's a distinct difference between what Dr. Lansky talked about and what people theoretically thought would be the case in studying genetics. There's a difference between genetics and genomics. See, in genetics, we can tell someone's genes and make predictions, hope they're right. Whereas in genomics, we can see the product and the activity of those genes, the genetic process. We can then follow the disease and see what's happening. We can measure therapeutic responses, not by predictions, by guesses, but by what's actually happening in that individual patient. Again, the Human Genome Project has allowed us to get insight into an individual's biology. You see where I'm going with this. This has nothing to do with man versus woman. This is individual. I want to point out in the PREDICT trial, they weren't dealing with a guess, a marker where, like CRP, you check a marker and you see what happens. Are we going to get coronary disease or not? These were patients who had coronary disease. All of those patients went to the cath lab. They know what the anatomy is. They got the RNA that matched that particular anatomy. So again, there's no question about whether this is real. But the question really is for us in clinical practice, can we rely on that value? Can we rely on the chorus number for the patient who's just walking in our office? Because that's what's more important, right? I mean, the patient's walking in with chest pain. We wonder, hey, if I got a chorus on you and I got a number, does it have the same level of prediction? Does it have the same value as we know it does when we take you to the cath lab? That's what the COMPASS trial set out to determine. This is an independent validation study, of course, in stable patients. Stable meaning didn't need to be in the hospital. This is not acute coronary syndrome, but stable enough that they're having symptoms, but we can treat it in the outpatient setting. All patients were referred for MPI, myocardial perfusion imaging, and this is more reflective of a real-world setting where patients walk in your office and see what we can do. This is a prospective study, multiple sites, the same core lab and the same illustrious steering committee. And the purpose of this, or in taking symptomatic non-diabetic patients, again, was to see what is the value of using course upstream in such a population. So patients came in. All patients had a stress test. If the myocardial perfusion imaging, if the MPI was positive, they went on for coronary angiography, normal standard of care. If the MPI was negative, we still needed to know the anatomy. So CT angiography was taken. And if there was high-risk anatomy, then went on for invasive coronary angiogram. What you found is that, and you can see on the top line, that the sensitivity of obstructive coronary disease or the process of obstructive vasculopathy was picked up in core CAD. You can see 89% versus MPI. But more importantly, the negative predictive value also outperforms myocardial perfusion imaging to a degree that currently surpasses anything we use currently in modern cardiovascular diagnostic medicine. This is a graph that shows how, as you can, I'm sure, imagine, the more inflammation going on, the more procoagulation going on, the more thrombosis going on, the more you're going to have pro-inflammatory markers. The more you have the markers, course actually puts them on a scale of 1 to 40. So while it's important to notice that the higher the score, the more likely you have obstructive disease that you see in the abscissa versus the X on the bottom, what's more important for us in clinical medicine is if you look all the way to the left, those error bars do not cross the significant patterns. They do not cross over with the patients who have obstructive disease. So, translated or another way stated, if you have a score of 15 or lower, which is all the way on the left, you've effectively ruled out obstructive coronary disease. So, potential paradigm where many in the country, including myself, uses CORIS. Actually, we're on the EPIC system. I know if anybody's into EHRs or anything like that, we got our group to actually use CORIS and put it into our EPIC system, where patients who come in with chest pain will get, the CORIS test. And up front, what we'll do is patients will come in with chest pain, they'll get a CORIS test, and if your score is less than 15, there's no need for further testing. We'll go and look for non-cardiac causes, GI workup, musculoskeletal, et cetera, et cetera. But what if your score is greater than 15? Well, they'll go on for myocardial perfusion imaging. And if on myocardial perfusion imaging, if you haven't already determined that this is obstructive coronary disease, if their imaging is negative, there's no need to go on for further testing. But if it's positive, you have a positive nuclear scan with a positive CORIS score. You're talking about someone who's actively obstructing the arteries. You can send that person to catheterization. And compared to what you've already heard about catheterization, your diagnostic yield of the catheterization is significantly higher. More importantly for the patient, what you're doing is you're appropriately sending the patient to cath, who should be in cath. And you're avoiding the excessive radiation risks and dangers in patients who should not be there. Parallel in that is that if your CORIS score is high, that actually identifies people who you do have to watch out for, people who you do want to bring back and keep a close eye on, where if your non-cardiac intervention doesn't work, maybe you do want to jump in and consider something else. But you're still in a relatively low risk because the nuclear was also negative. This is a very simple test. It's been done in over 55,000 patients. Medicare's covered it, and this is an actionable, strong, reproducible test. It has more clinical relevance for us in practice than anything else that we've currently used. It also is able to weed out probably half of the patients who really shouldn't go on for further wasted resources in cardiovascular medicine. You can take the gender and be normalized based on these genes, and we can find out with a negative predictive value of over 96% who should and who should not go on for further evaluation, thus using the resources appropriately where they should be. I just want to show a few illustrious cases. So the first one, this is one of our colleagues out in New Jersey. He shows a 51-year-old female who came in with shortness of breath, chest pain, palpitations. She smoked, and she was on blood pressure medicine. CORIS score came back at 2, meaning that the likelihood of having obstructive artery disease is very low, 2. If you remember the score for CORIS was 1 to 40, 15 or lower was pretty much negative. So looking at this, the cardiologist said, well, with 2, the chances of her having obstructive disease are extremely low. If people haven't had a sheet back yet, this is what you get, the sheet on the left, which shows you where your patient is based on the age-matched cohort and what that person's score is. Because the score was so low, this particular cardiologist decided against the stress test, against going further down the cardiovascular pathway, and was able to use resources to figure out and treat the non-cardiac chest pain appropriately. This was an 80-year-old atypical female with substernal chest pain and shortness of breath. High blood pressure and high lipids. She's already on the appropriate medications, right? Beta blocker, statin, aspirin. Her BMI is 28. Just going to say it's outside of the normal ranges for BMI. Nonetheless, she had a treadmill that was inconclusive, like everyone here is surprised. EKG was normal, chest x-ray was normal, but her score came back at 29. Myocardial perfusion imaging? Cath? Cath. All right, so everybody's saying cath. How many surprised that we have an 80-year-old on a treadmill? That's what really got me. I was really impressed. So quite honestly, at a score of 29, it doesn't tell you whether it's one vessel or multiple vessels, but at a score of 29, that was pretty high towards the right. And so this person actually went straight to the catheterization lab where 99% marginal lesion was seen, and she had angioplasty and stent. So in that case, you know, again, I'm not advocating that the chorus high scores mean everyone goes to the catheter. But in my mind, and what I've been doing, is that if your score is over 15, you are not safe. So if you have symptoms and everything else is not working, I'm going to have a low threshold to treat you for coronary disease, as opposed to people who have 15 or lower. I'm pretty confident that those people have been excluded from having coronary disease, and that gives us time and saved resources to help the patient get what he or she needs, predominantly to fix the chest pain.